tell you a little bit about hepatitis C in 2018. These are my disclosures. And I think one of the important things to always remember is, why are we even worried about viral hepatitis? Well, because if you look at the leading causes of mortality between 1990 and 2013, you can see that actually viral hepatitis is among the most prominent infectious diseases leading to death. So whereas everything else is around cardiovascular disease, the lung, respiratory infections, and so forth, viral hepatitis is really up there. It's the 7th most prominent cause of death, and as such, obviously needs urgent attention. And if you remember that viral hepatitis is responsible for around 1.4 million deaths per year, I think we all understand how important it is to diagnose viral hepatitis and treat it appropriately. I think one of the most exciting presentations in the last years around hepatitis C has been the release of the new WHO report on hepatitis C. Because remember, if you open a textbook of medicine, and I see some authors in the room which have written similar textbook chapters, you will see 140 to 180 million people are infected with hepatitis C. But when you look at the WHO report, it went down to 71 million. Now that is the biggest cost-saving effort ever done, because you don't have to treat people who don't have hepatitis. So I think there was an overestimation of cases. Remember that probably around 30% of people who get infected with hepatitis C can clear infection spontaneously. So obviously you can only look at those who are replicating. That brings the number down. And then I think the estimates of hepatitis C worldwide are still not optimal, because in many countries we do not know the exact prevalence of hepatitis C. And that includes obviously some African countries where you also have some bias, because if you test for hepatitis C, you have a lot of false positive because there's cross-reactivity with bilharziosis, for example. So there are also some issues with antibody testing. But even in a country like Germany, where you think they have money to pay for everything, there's not a good figure of the true prevalence of hepatitis C due to the lack of larger epidemiological studies. The other important point to appreciate is that if you look at the amount or number of persons infected, and you look at the different regions in the world, you can see that every region is affected, including the African region, the Asian region, and so forth, telling us that there has to be a global strategy to fight hepatitis C. It cannot be something which is done only in North America or in Europe. Now, obviously, with regard to HIV and hepatitis C, there are similar transmission pathways, and so we estimate there are at least 2.3 million people co-infected with hepatitis C. And if you are from a country where IV drug use is the main driver of the HIV epidemic, your amount of patients with hepatitis C will be much larger. And you can see that on average, injection drug users have a rate of co-infection of 80%. But you can also see that men who have sex with men, MSM, are also increasingly being diagnosed with hepatitis C. That's another risk group for that infection. If you look at the cascade of care, something we are very familiar with as HIV doctors, we know that we're talking of 90, 90, 90, and we have first countries like Sweden who say we have 90% of people with HIV diagnosed, linked to care, and treated successfully. But if you look at hepatitis C, you can see these figures are dismal. Dismal in particular if you look at the proclaimed 2030 targets, which the UN Assembly agreed upon, to have 90% of people with hepatitis C diagnosed, and you can see that so far it's only 20%. So a huge gap between what we want to achieve up to 2030 and what is currently the truth. And you can see how few have been cured in 2015 in their consideration of the whole amount of patients. So there's really a lot to do. Now, access to hepatitis C therapy has changed quite considerably. So in many countries, it started with a prioritization for patients with F3 and F4 fibrosis only. So only if you had like pre-cirrhosis or already manifest cirrhosis, you were eligible for treatment. But now if you look at the large European countries, Germany, Spain, Italy, France and UK, you can see that in most of these countries there is no restriction anymore. But you can see that screening programs are not available in most of the countries. National plans are not available in most of the countries. And so although there are no treatment restrictions, we're not doing a big effort in finding all of those who have hepatitis C. And that leads to the point that the number of patients who are diagnosed are still far too low to reach the WHO 2030 targets. And I think in this whole process, obviously, it is easier for some countries than other. And that's something we also have to appreciate. So if you are from Iceland, and I don't know if we have someone here from Iceland, but it is a very small patient population, and they estimate that they only have probably around 1,000 individuals who have hepatitis C. Now, if you only have 1,000, that's probably as many patients as one has in his clinic. So that's like, I'm going to treat all my patients in my clinic in Seville, and then I got Iceland elimination achieved. So it's going to be a whole different challenge, obviously. But I think what is great is that they say, well, since we have this possibility of only having so few, let's treat them all. And indeed, most of the patients in Iceland who have hepatitis C are IV drug users. So they have developed specifically programs in the addiction hospitals. So anywhere where they offer methadone substitution, support, they also approach patients for treatment and have as such successfully treated now 3/4 of their patients. 80 to 85% have been evaluated or initiated on treatment. And as a consequence, the prevalence of hepatitis C has dropped dramatically by 73%. So it shows you that if you identify your patients, treat them, you can actually change your epidemiology and come to a marked reduction in hepatitis C cases. So that, I think, is the good news. You can achieve microelimination. Obviously, if you're in a country where you have 300, 400, 500,000 patients, that's going to be a whole different ballgame and much more difficult to achieve. Georgia is another example of an outstanding hepatitis C program. Now, many people are envious because they say, well, they got the drugs for free from Gilead. But I think what we can learn from the Georgian program is that actually, in a country which is not the richest in the world, if politicians, activists, and doctors get together and fight for the best, then I think many things become possible. So the reason why the country was chosen has a lot to do with a very strong leadership and will, and a politically willingness to get hepatitis C eliminated. And you can see that of the estimated 150,000 with hepatitis C, 1/3 has now been diagnosed and initiated treatment. Half of them have been cured. So it tells you that even in a country with a very large proportion of hepatitis C infection, things are going very well, but clearly there will be the challenge of finding those other 100,000 which are still missing, and that is going to be a challenge. So a lot has to do with our current approaches for hepatitis C screening, and there are obviously various ways we can do it. We can wait till someone gets symptomatic, liver signs, skin signs, turns yellow, or any other clinical manifestation of liver disease, but obviously then he's already progressed to advanced liver disease stages, and it may be too late to benefit from therapy. So that is not our best way forward. So in order to intervene before disease progression occurs, probably every country will have to think about what is their best approach, and most likely will be testing at-risk patients, depending on how high your prevalence is. So in a country like Germany, where the prevalence of hepatitis C is probably around 0.3 at the most, probably lower, then it's not cost effective to screen the entire population, and you will have to start screening patients in defined risk groups, so people who ever enjoyed IV drug use or got blood products or perinatal screening and other things, which I think would be cost effective. The question, though, is our general practitioner going to ask these questions? And that is a lot about taking history, the medical history of a patient, where sometimes these things are simply not asked, and where you don't ask, you're also not going to find or establish corresponding diagnosis. I think you're all very well aware of the tremendous successes in the development of hepatitis C therapy over time, and it is quite an impressive story. Thinking of hepatitis C being discovered in 1989, so not so long ago. And then in those days, even before the discovery of hepatitis C, there were very courageous investigators from the NIH already started treating patients for non-A, non-B hepatitis with interferon with very poor response rates. And then obviously with the addition of ribavirin, the introduction of easier to administer once weekly interferon, pegylated interferon, we were able to suddenly cure maybe at best half of our patients. So we're still half of the patients were failing, and that was much higher in the co-infected patient population, where only a third of patients responded even to extended durations of interferon ribavirin therapy. When the first DAA was introduced, around 2011, telaprevir and boceprevir, you saw a sudden increase in response rates over 70%, and what followed very fast thereafter was that the combination of all oral DAA therapy then allowed cure rates of over 95%, and that has become now the standard of therapy. So if you give hepatitis C therapy, your cure probability should be above 95%. And this has all become possible through drugs in mainly 3 drug classes. And since the amount of drugs is increasing and you have all these weird names which are difficult to memorize, particularly when you are in the aging part of your life, you will then help yourself by looking at the endings. So any protease inhibitor will end with a Previr, any NS5B inhibitor will end with Buvir, and any NS5 inhibitor will end with Asvir. So that's how you can separate. And usually it's a combination of two different drug classes is the standard of therapy. Listed here are the various drugs available, and you can see that in green are telaprevir, boceprevir, which are hardly available anywhere anymore. They are coming with quite some considerable toxicity, skin rashes, and so forth. And they also obviously were given in combination with PEG and RIBA. So now in the era of only all oral DA therapy, these drugs are no longer used. Black ones are the ones which are commercially available, and you see a lot of drugs in red, but really at last year ASLD, all of these drugs were sort of terminated in their clinical development program. So although they had good results, none of them was able to show added value over what is already available. And so I think we must expect no further hepatitis C drug to be developed, and we'll live with the drugs we have, which obviously allow great efficacy. So really, we already have reached the end point of hepatitis C drug development. And what has hepatitis C care evolved to? Well, we have very short treatment durations of 8 to 12 weeks. We have pangenotypic regimens, so really genotype assessment may not be necessary if that is an issue because of cost. And because of the very good safety profile of these drugs, we have minimal monitoring requests, which sort of tell us that we have come a long way. And obviously, minimal pre-test requirements and minimal monitoring is the extremely important step for getting global implementation of hepatitis C therapy, particularly in Africa. I've listed here the various drugs which are available in 2017 and 18, and I think it's fair enough to say that many of the drugs are no longer in use. So on the right-hand side, you see some of the non-pangenotypic regimens, the ABRI3D regimen, abitosvir, paracetprevir, plus tisabevir, at least for genotype 1, not for genotype 4. And that, for example, is now withdrawn from the German market because in favor of pangenotypic regimen, that's no longer used. So it really depends a little bit on which country are you coming from, what are the price negotiations with the companies, and what drugs you have available. So I think all of these combinations work, but clearly there's a tendency to use pangenotypic regimens. Now, one important, I think, uniform message from all of the guidelines, be it ASLD, WHO, or EASL, is that every patient with chronic hepatitis C should be considered for therapy. So even if there are countries which say we have restrictions because of cost, the guidelines clearly say any patient with hepatitis C, regardless of fibrosis, has an indication for therapy, and the only exception would be a very short life expectancy because of cancer, for example. Now, the goal is obviously to cure, so very different to HIV. Hepatitis C can be cured. So if your hepatitis C RNA is negative 12 to 24 weeks after stopping therapy, that is considered cure. And you want to cure because you want to prevent complications of hepatitis C-related liver disease in particular, but you also want to improve quality of life, remove stigma. Remember, a lot of people have stigma around their hepatitis C infection. And you also want to prevent, at least in the setting of IV drug use and MSM, where it occurs in the transmission occurs in the setting of traumatic sex practices, you want to prevent onward transmission. And we already pointed out the endpoint is 12 to 24 weeks after therapy and negative hepatitis C PCR. It's important that there are still some pre-therapeutic assessments, so you want to see are there other comorbidities, and you also want to know the liver disease severity. And that's important because if you are cirrhotic, that requires certain monitoring steps. Also, after achieving hepatitis C cure, you will have to look for hepatocellular carcinoma and regular intervals. So there's still some things you want to know, and that's mostly what is your liver fibrosis stage. That can be at best done by non-invasive markers, and we'll have a talk at the end of the session which will deal with that in much more detail. And don't forget, if you already have liver disease, you really want to avoid other causes of liver disease. So please remember to vaccinate your patients for hepatitis B and A. The regimens which are recommended by the guidelines, and I've used the EASL practice guidelines because they were most recently updated in the context of the Paris EASL meeting in April, is interferon-free, ribavirin-free regimens for all. So it's now really no ribavirin, no interferon in patients, be it with cirrhosis or without. And the same regimens are recommended for patients who have hepatitis C as a monoinfection, as well as for those who have HIV and hepatitis C. And that's very important. So all these things in the old days where we had different durations and dosages, all disappears. HIV patients with hepatitis C are to be treated exactly the same, but remember, you will have to check for drug-drug interactions. There's a wording also saying that you should prefer 2 drugs over 3 drugs, and that has a lot to do with that. In the very unlikely event of failure, 3 drugs is your salvage option, so use the 2-drug regimens first for that reason. Simplified pangenotypic regimens are preferred, so they say in the setting where that's available. It also allows to skip some of the pretreatment assessment workup other than the non-invasive tests for liver fibrosis. And so soft valpatisvir for 12 weeks or the fixed dose combination of glucaprevir and preventosvir offer 2 promising pangenotypic regimens which can be used for all genotypes and all patient types. Exception would be you can't use a protease inhibitor in child B or C cirrhosis. So that's always important. Remember, hepatitis C protease inhibitors get too high levels and may have a risk for toxicity in advanced child B and C cirrhosis. In patients who have no cirrhosis, glucaprevir and preventosvir can also be administered for 8 weeks, which may be an advantage in the setting of patients with adherence issues. Also note that generic drugs are considered to be used if there is quality assurance. There's a lot of data, particularly from Egypt, showing excellent results with generic treatment, so that's clearly an option. Drug interactions have to be checked. That's very important. There are websites like this one from Liverpool, which allows you very reliably to check for interactions. Remember, this is particularly true for hepatitis C drugs and HIV drugs. So commonly we would say, yes, drugs which are metabolized by the cytochrome P450 system, so HIV PIs, hepatitis C PIs will interact, and that will possibly not work. But remember that also there are interactions through renal transporters and PGP, and so valpatisvir, for example, cannot be given with efavirenz, and that's an issue because WHO still has efavirenz as a first-line recommended regimen, and that will change shortly, but I think it's important to note that there are sometimes unexpected drug interactions which you will need to control for, and obviously, in particular for PIs, that is a big issue as well. But remember, SOF and NS5A inhibitors usually always work, so we have enough hepatitis C drugs and enough HIV drugs to find combinations. I think it's important to at least mention that you also have to check for other drug interactions for other agents, and proton pump inhibitors have been particular concern. because at least if you gave them at a high dose and twice daily, they lowered the overall hepatitis C cure rate when you were giving sofosbuvir ledipasvir. So PPI does affect the absorption of valpatisvir and ledipasvir, and so you can only use a lower dose, and you have to give it concomitantly with your DA therapy. So remember, there are also other drug interactions, and you have to check every drug the patient is taking. The main reason why we're treating is obviously because we improve liver disease outcome. So all studies already in the interferon era showed you're less likely to die from liver disease, you're less likely to receive liver transplantation, and you're less likely to develop liver cancer. All good reasons why you want to cure hepatitis C. In the subsequent years, we have seen, though, also data which tells us it's not only in patients who have cirrhosis, but even in the setting of F0, F1 fibrosis, you already see in this Kaplan-Meier analysis the curves over time going apart. So your survival benefit is even there if you have no advanced fibrosis. One of the strong reasons why you should treat patients with hepatitis C, regardless of fibrosis stage. And more recently, there's also data looking at other issues. Remember, chronic viral infections cause inflammation. Hepatitis C also causes insulin resistance. Does that all enhance cardiovascular risk? So looking at patients with SVR versus not, you can see that indeed cure of hepatitis C comes with a decrease in major cardiovascular events. This is the first study from EASL 2017 from the French group, and this was reconfirmed at this year EASL from the Italian group, again showing the huge impact on liver mortality, but also showing that you were less likely to die from cardiovascular disease in the setting of obtaining cure for hepatitis C, and this time through DA therapy. Now, the drugs have obviously improved, just showing you the outcome of the Astral phase 3 trial data. So 12 weeks of soft-val in all genotypes worked very well. And the only remaining little gap, potentially with only 95%, but I think we agree 95% is already a great response rate, were 11 relapses in genotype 3. So genotype 3 remains just a little bit more vulnerable. And so at this year EASL, there was a study looking at soft and val for 12 weeks versus soft-val plus ribavirin in genotype 3 patients with cirrhosis, because that's where you sort of wonder, is that 5% risk potentially decreasable by adding ribavirin? You see this is sort of an average patient group. There was also a number of patients included who had HIV co-infection, mostly male patients around 50 years old. And you can see that indeed by adding ribavirin, you were able to decrease your relapse rate. So in patients, as it turns out, in those, I didn't have that in there, but in the patients who have the 93H at baseline, so if you have resistance-associated variants at baseline, you may overcome that by adding ribavirin in cirrhotic genotype 3 patients. This is the GP data for 8 weeks in non-cirrhotic patients, and you see in all patient groups with all genotypes, regardless of any patient characteristics, fantastic overall cure rates. You see that the prolongation to 12 weeks in genotype 1 to 6 leads to excellent overall cure rates in treatment-naive patients. So clearly, efficacy has improved and reached really very high rates altogether. And I think this is probably, from a patient point, the most important slide, because the tolerability of these regimens is excellent. You can see that the amount of patients who discontinue because of adverse events is less than 1%, really telling us that administration of these agents is easy and safe. Just one word on retreatment. So what do we do with those 2 to 3% who fail? And there has been data from the soft-val Vox, so the 3 drug classes combined in 1 tablet. And there's also been at EASL, and that's why I chose this study, data on glecaprevir, pibrentasvir, so patients who already failed in the licensing trials, the GP regimen, were then retreated with the addition of sofosbuvir, and you can see that all of those patients almost achieved cure. So a 3-drug class approach as a salvage therapy, even the setting of prior DA failure, works very well and is a good option forward. So in summary, I think all treatment-naive and experienced patients with hepatitis C should be considered for all oral DA therapy. I am sure that there are countries where there are still access limitations. I think it is a combined effort, and it's really in the end not so much a question of resources and price, but a question of political will and leadership to make access possible, and obviously it has to do with price negotiations as well. I think we are beginning to understand that the benefit of cure, even in the setting of no fibrosis, goes way beyond improving liver disease outcome. It could have an impact on cardiovascular disease. It definitely has an impact on neurocognitive function and fatigue and quality of life. I think one important thing in practice to remember is the value of drug-drug interactions and using websites to control for that. Remember that there have been some warnings around reactivation of hepatitis B. I haven't mentioned that, but if you initiate DA therapy, there should be a hepatitis B serology, and in the setting of HBs antigen positivity, you may want to treat hepatitis B to prevent increases in HBV DNA levels. And I think what we're left with as clinicians is to work on better screening programs to be able to reach the WHO targets for 2030. And with that, I'll end with a friendly hello from the Bonn Co-Infection Research Group. Thank you very much.